it's a topic which carries huge pathology. And I think it involves both nephrology and urology. It involves both lower urinary tract and upper urinary tract. So it is one of those areas where the time limit is of great importance. So I don't think I will be able to do justice with this topic in this half an hour, 45 minutes, but I'll try to highlight some pertinent areas and concepts related to posterior urethral valve patients and some initial management of these patients. A little bit about epidemiology, that it is urinary tract, one of the commonest cause of bladder outlet obstruction in infants. And the prevalence is about 1.6 to 2.2 per 10,000 births. In the past, all these children used to die because of renal dysfunction and compromised renal function and sepsis. But with the improvement in management, with better understanding, with prenatal diagnosis, neonatal ICU care, these patients survive and live a longer life with compromised renal function, particularly. And they are they have huge economic repercussions in terms of dialysis and renal transplant. And I think same goes for their urological management as well. Is they need a lifelong urological care, they need lifelong nephrological care. So coming to the classification, it was 1819, I think, about 100 years back, that Hugh Hampton Young gave this classification, and the commonest type, which we still recognize, is type 1, where the leaflets arise from the verumentinum and take an anterior course and then fuse in the midline just proximal to the external striated urethral sphincter. So they are the most common type of the posterior urethral valves, type 1. And the type 2 has become now obsolete, which are basically the hypertrophied cristae which run from the verumentinum to the bladder neck, and they were labeled as type 2 valves arising from the verumentinum and extending posteriorly superiorly to the bladder neck on the floor of the posterior urethra. So they are obsolete. And there is a third type which presents as an annular ring a little below the verumentinum, complete annular ring attached to the entire circumference of the urethra, there being a small opening in the center. And there is a controversy about it, this opening in the center. I'll come to it later. And newer concept was given later on by Diwan, that this is a complete membrane, which they labeled as congenital obstructing posterior urethral membrane, COPM. And they say that there's no hole actually in it. And once we intervene with a catheter, you create a hole, and when the people scope it later on, they find that hole, and that's why they have labeled into two flaps and valves. So, and there are different embryological bases which have been proposed. One is hypertrophy of the urethral mucosal folds, cloacal remnants, abnormal development of Wolffian and Mullerian ducts, because they converge at this level, abnormal insertion or absorption of the Wolffian ducts. So they say there's the hypertrophy of their distal mucosa, or this complete obstructive posterior urethral membrane, which is again failure for this membrane to resolve in some cases. So whatever the embryological basis, because it is not completely proven, these valves are nasty in most cases. But the presentation again is very, very variable, and different aspects and different mechanism play their part, and that's how the patient are presented. Some during fetal life, they destroy their whole kidneys in the urinary tract, or some can preserve good renal function to a certain extent, or at least one kidney, and they can live with that kidney. And the bladder does not get damaged to that extent that they need a lot of care for that. But majority do have severe pathology of the lower urinary tract, upper tract, kidneys. There is dilatation of the posterior urethra, the hypertrophy of the blood because of the obstruction. As these are mostly adult urology or general urology resident, they are well versed with the bladder, with the BPH or the prostatic obstruction, which if it is neglected, then how it affects, or a stricture urethra, if it is not taken care of, then it again causes the same kind of problems with the bladder or any kind of bladder outlet obstruction, the thick-walled bladder. It can cause reflux, it can cause secondary obstruction at the uterocycle junction, and then hydronephrosis of the upper tract and renal atrophy. All these can happen. Neuropathic bladders. So same thing happens in the neonatal in the fetal life, that there is dilatation of the posterior urethra, hypertrophy of the bladder neck, flattening of the verumentinum, dilatation of the ejaculatory duct, and to the extent that the urine production is not enough. This is one of the hypotheses, or there is not enough amniotic fluid in the womb. So the lung gets, there is pulmonary hyperplasia, and may be fatal in some cases, or it leads to severe pulmonary dysfunction in the later life or in the neonatal life. Infants, sometimes the infants have stillbirth, or if they survive, there are long-term problems. Similarly, as I said, that the upper tract problem, the back pressure effect, the globe, there is obstructive uropathy, this reflux or obstruction can cause renal dysplasia, tubular injury. So there is a lot of damage to the kidneys, sometimes to the one kidney, sometimes to both the kidneys, depending on how the patient and the urinary tract has reacted to this bladder outlet obstruction or the posterior valves or this membrane. The obstructive part of the renal insufficiency, to a certain extent, and if it is the obstruction is relieved early, can be reversible. But if this renal dysplasia has taken place, which is one of the phenomena which happens in reflux nephropathy or in obstructive uropathies in the early development of the kidney, then it is usually irreversible damage to the kidney. Tubular injury is again a phenomena of the obstruction and we see the effect of relief after the relief of obstruction. It can lead to nephrogenic diabetes. It can lead to like a loss of concentrating ability, and these kidneys become polyuric, or these patients become polyuric. The concentrating ability is lost, and that polyuria or diabetes, nephrogenic diabetes does play its role on the management or the function of the lower urinary tract or the bladder. Bladder, because it has been working against that obstruction, it leads to a thick-walled, hypertrophied with diverticula. It can poor sensation, hypercontractility, low compliance bladder, and eventually there can be myogenic failure, and that leads to a lot of voiding dysfunction. And these bladder problems are lifelong, and there is they behave differently during their lifetime. That's why I said that these patients have to be followed all their life by urologist as well as nephrologist. There's effect on the ureter, the dilated tortuous ureter, there's fibrosis in the walls, there's lack of contractility. Even if you relieve obstruction, their peristalsis is affected. There is some improvement, but not completely and not in all cases, even if you relieve the obstruction. So they behave differently. Every patient behaves differently. So of course, there is a general pattern, but each and every individual behaves differently, and you have to follow them independently. There's a very well-known term for this well bladder syndrome or well bladder, which is a an effect of the same which has happened to the body, that that there is renal dysfunction, there is polyuria, there is reflux, there is renal dysplasia, the bladder wall has been is hypertrophied. So this goes on, and it leads to sometimes excessive urine production, post-void residues, the bladder never get rest. So this has been labeled as well bladder syndrome. I'll come to it later on how it works. So the common presentation of these posterior valve, of course, in the fetus, because it's a congenital abnormality, they can present in neonatal life, they can present at infants, or some of them, as we see, that they have not been, either the parents have not noticed, or some of them are not that severe, to be honest. And they are missed, and they can present later in life. And of course, one of the major reasons of missing them is their lack of good routine gestational ultrasound. All these urological congenital abnormalities can be picked up and followed up if we have a good routine gestational ultrasound where they look for urological anomalies. So coming to the fetal presentation, that this valves or valvular obstruction can develop in fetuses at the age of 7 weeks of gestation. But usually the kidneys are visible about 20 weeks, or we don't even go for an ultrasound that early. So these abnormalities are usually seen between the 16 to 20 weeks anomaly scan, when the anomaly scan is done. And when they look for urinary tract, they can see that there is bladder with dilated posterior urethra, and this is a very famous sign called keyhole sign, or you can see hydronephrosis into this kidney, left kidney, with a dilated, with a full bladder and dilated posterior urethra. One of the ways of looking at it, when you're doing an ultrasound and the bladder is full, that you wait for half an hour. Usually the fetus empties during the examination or within half an hour while doing an examination or post the urinary bladder. If the fetus doesn't empty the bladder, that means there is some element of bladder outlet obstruction, and the commonest cause could be posterior valves. This is another presentation of a fetus, bilateral hydronephrosis. You can see the bladder full again, consistently seeing the full bladder on repeat ultrasound means that there is some bladder outlet obstruction. You can see this dilated hydroureter as well. So this is different from PUJO, where we did not see the full bladder, consistently full bladder. We did not see hydroureter. There was a just dilated pelvicalyceal system. And this is hydronephrosis, hydroureter, and a full bladder. So with such findings, an obstetrician refer these pregnant ladies to you, then how to counsel them and what precaution, what further management you can do. So one of the things is that you have to counsel. It is not like PUJO where we said you have to mostly reassure and no intervention can be done. You don't have to do anything. In such cases, if they are picked up early and they are severe cases, you can just take 20 weeks, you see oligohydramnios and bilateral hydronephrosis, hydroureter, and reduced cortex, then you can even suggest discontinuation of pregnancy because the fetus is not viable at that time. You can't do that by the end of after 27 weeks or so. But you have to tell them the factual position depending on the finding. If the adequate liquor, there's mild dilatation, it's hydronephrosis, hydroureter, you can give them a differential diagnosis. The bladder doesn't empty, then definitely it is one of the bladder outlet obstruction, but the other possibility could be, apart from posterior valve, it can be urethral atresia, it could be prone belly syndrome, but they are rare. The commonest is posterior valve. The second thing is you have to ask the mother to get herself registered with particularly in Pakistani context, when they go at the last moment for delivery, that they have to get themselves registered to a proper obstetrician and a proper hospital where they have a neonatal ICU. When the baby will be born, if the things, even if things doesn't get worse, then there is, as I mentioned, there is a risk of pulmonary hypoplasia and respiratory distress, and patient may, the fetus, when delivered, can be sepsis with electrolyte imbalance, so they would need neonatal ICU. So they should get themselves registered in a neonatal ICU and parental counseling. Other things in the developed world, that they are doing some antenatal intervention, which is again for very limited kind of cases, and there has not been consensus about it. There are no randomized trials. They tried to do the randomized trial, which did not register many patients. They could not get an outcome, so they abandoned those trials. So there have not been any randomized trials, but there have been hundreds of cases of antenatal intervention, particularly the vesicoureteric shunt, particularly in cases where you have oligohydramnios, dilated bladder, severe hydronephrosis. And there are some amniotic fluid criteria, just like sodium chloride. These are the things which they assess. On that basis, if they are favorable, they do vesicoamniotic shunting or uterine interventions. And the options are vesicoamniotic shunt, intrauterine valve ablation, termination of pregnancy, as I mentioned earlier, in severe cases, and before the fetus is viable. And then the other option is that you can do a preterm delivery. So I'll talk a little bit about vesicoamniotic shunting. In cases where there's what you do, that you put just like you do amniocentesis, you go in and you put a double J stent like thing between the fetal bladder and the amniotic cavity. And that's how the bladder can drain with this stent into the amniotic cavity, and then that diverts the urine. So this is done in highly selective cases and highly selected center. The other intervention has been that people have tried to go in and ablate the valve. They go in percutaneously and ablate the valve with a laser antegratally. There have been a lot of complications. The pregnancy had to be terminated. They have burned the urethra during these procedures. So this is not a very popular treatment. And I am sure that all of you have seen a microperc all-seeing needle. So people have used that all-seeing needle, microperc needle, to go into the bladder and to ablate the valve with a laser, whole beam laser. So this is a little bit of antenatal intervention. Or what can happen to the fetus? You can have a child with a Potter's facies, with pulmonary hypoplasia. We can have twisted skin, wrinkled skin because there's not enough amniotic fluid. You can have feet deformities. You can have hand deformities because of that. And this can even lead to stillbirth or neonatal death if it's a severe case. So coming to those who are not that bad, though they survive, but moderate to severe cases that they need to go to ICU. Because of the pulmonary hypoplasia, because of the electrolyte imbalance, and the best thing is that they should be taken to the ICU, and a small feeding tube, 6 to 8 French, is passed through the urethra into the bladder to divert the urine or to clear the urine to relieve the obstruction. And once all these they are stable, then they need to be referred to the pediatric urologist. They should not come to the pediatric urologist before that. Once the sepsis is over, once the electrolytes are correct, once the respiratory distress is gone, only then they should be referred to the pediatric urologist. And once they come to pediatric urologist, one should ask about the voiding history. Usual presentation is that they strain, they cry during voiding. There is no continuous stream. There's intermittent stream, or they void in drops by drop. There is dribbling of urine. Child is failure to, or if they are little late, they're failure to thrive. They are not taking feed normally. All this various kind of presentation. So voiding history is very important. On examination, you have to look for the genitalia. because similar findings, wording abnormality or wording history can be due to phimosis, simple phimosis. So in that, the circumcision will take care of it. But physical examination, back examination is very important because you have to exclude any neuropathic element in these cases. Definitely electrolytes have to be checked or renal function have to be checked. But I must mention that the first few days, but up to even 8 days, that the creatinine urea is not very important because they reflect mother creatinine renal function because it's being cleared by the placenta. And then the foremost investigation, which gives you an idea about the diagnosis, is ultrasound. On ultrasound, you can see full bladder, you can see a thick wall bladder, you can see dilated, you can see both dilated distal hydroureters, and then you can see hydronephrotic kidneys. Then one of the earliest investigation required once the patient is out of sepsis and the culture is negative, and you have placed a feeding tube or a mini P, that is percutaneous tube, which is like a pigtail tube. Just you have been doing a Foley kind of suprapubic, but this is a pigtail-like tube, 5 French, which can be placed. It's very useful in such cases. So better than, because when you pass a feeding tube per urethra or a catheter, it's very difficult in severe cases to go into the bladder. It can curl into the posterior urethra because of obstruction or below that. Or you need a Cody catheter, you need to have a guide wire and curve it. So in those cases, particularly, you can, and it's easier to keep it with a stitch. You can do a good cystogram by using a mini P, 5 French mini P or suprapubic. So, sorry?
Kindly keep the audio off. The questions, answers will be in the end. And
okay.
Write down in the chat box if you have questions. Please do not interrupt the presentation.
So then the foremost investigation after ultrasound is on baseline blood and urine analysis and electrolyte is micturating cystourethrogram. And you can see a variety of presentation that there's a small thick walled bladder with divertically and bilateral high-grade vesicoureteric reflux. And the bladder neck is not opening up in this case, but in this case it has opened, and this is the dilated posterior urethra, and this is a typical presentation of the valve. It is said that the valve diagnosis is a cystogram diagnosis. So you can suspect that this is a valve case with bilateral reflux, high-grade bilateral reflux. Similarly, another cystogram, yet another, this is after voiding. So there is still residual urine, there is still reflux urine contrast into the collecting system. This is a bigger boy where you can see lateral film, you can see the valve-like bulging membrane, diverticula, a larger bladder as compared to the small bladder. This is because of obstruction. Sometimes obstruction can lead to larger bladders in bigger boys, refluxes. This is a variety of, so this is again valve. So these are the variety of fixed presentation in cystogram. So whenever you have this ultrasound and cystogram and you have made a diagnosis, the other thing which is important in imaging and is to assess the relative function of the kidney, particularly when you are seeing refluxes, then DMSA scan is more important, which can tell you about the dysplasia, scarring, and relative renal function much better, because you're not concerned about the clearance. You have seen it on the cystogram. If the contrast has cleared up and come back to the bladder, that means it is not obstructed. But it can be obstructive refluxing, or there can be no reflux with thick wall bladder. Then in those cases, you can take help from a MAG scan. If they are good functioning kidneys or relatively better functioning kidney, there's hydronephrosis, you want to exclude this, or you want to judge the severity of obstruction. But in this MAG scan in valve patient, when you want to do MAG scan, you have to put a catheter in. You should look for clearance from the kidney with an empty bladder, decompressed bladder, not with a full bladder, because that causes secondary effect on the renal clearance. So now the next step, once you have made the diagnosis, would be to prepare the patient for get him assessed and anesthesia, and then go for cystourethropy, valve incision. And circumcision plays a very important role, because a lot of surgeries have been done that those between circumcised and uncircumcised, the incidence of UTI is much more those who are uncircumcised. So, and particularly in Pakistan, most of them religiously undergo circumcision. So why not to do it then and there? So circumcision and valve incision, I'll show you a video where cystourethropy is being performed. This is bulbar urethra, and now we're going into the this is, you can see that there's a high bladder neck. This is a kind of false impression as well, because they appear high because the posterior urethra is dilated. But in some cases, this bladder neck hypertrophy can still, once you have, even if you have relieved the obstruction by incising the valve, it can continue to be obstructed because of the hypertrophied neck, which are, but you, so this is a valve and this is the veru. You can see the fold coming from the base of the veru annulary and towards the roof, just below the stricta. It's very nicely visible. Well, these days we don't use these loops. In the past, we used to use very thin membrane, so you don't have to do a big cut. All you need to is just to, you know, the loop is visible behind that valve membrane. Nowadays, a lot of them are being incised with the cold knife, colon knife, or cold knife, but you can use the loop. And particularly when you have a thick valve and big bladder, you can create a stricture and you can do a thermal injury. So less and less people are now using loop. We have also changed our practice. We are now using cold knife. But there's a nice video already prepared, so I used it to demonstrate the valves and how to. It is not contraindicated. You can still use it with caution. It's a thin membrane. कितनी है? And how to examine it, that you have to, during cystoscopy, when you go, you look for the anterior urethra, posterior urethra, you go in, look for the ureteric orifice, the bladder wall, and then when you come back, when you are coming back, you stop the flow of the water or saline, whatever you're using. You can't use saline when you're using diathermy, you have to use water. And then you press the suprapubic area of the bladder, and then you can see that the valves is bulging before it. Okay,
मैंने ग्रुप पे शेयर की है जी, ग्रुप पे शेयर की है मैंने. ठीक है, मैं देख रही हूँ.
Hello. Yeah, lot of noise. Mute can first one.
Okay.
Yeah.
Right. So
the valve have been ablated, or you can incise with a cold knife, and then you can, usually it is recommended to repeat a cystogram in a month's time at least, to see that how is there any residual valve. You can see that the flow is better, the bladder and the ureters are much have improved further. So the other ways of managing posterior, the commonest way is, and the best way is to incise the valve and allow the bladder cycling and allow the patient to void per urethra. But in some cases where the patient is very sick, or they are living in long distance, or they are with renal dysfunction, they are with sepsis, then you may have to think of, or the bladder is very bad, you may have to think of some kind of temporary diversion, which one of them is vesicostomy. What we do is that we leave a catheter and we think that the upper tract have hydronephrosis has decreased significantly, and that means that it will work. So we make a hole. Bloxam vesicostomy is a recognized way of temporary diversion, or you may do one side ureterostomy or both side ureterostomy in severe cases which allows the kidney to drain easily from each side. Undiverting these bilateral ureterostomies is much more difficult. So until it's absolutely necessary for various reasons, the bladder is too bad, the uterovesical junction is secondary to obstructed, there's renal function, there is sepsis, or the patient lives far away, they cannot have a follow-up, regular follow-up, and you want to preserve the kidney. The whole objective is that that you want to preserve the kidneys for a few more years. And then once the child is big enough, school going age, 5-6 years, then you can revert these uterostomy. In better circumstances, you can do them early. So the other way is that in some cases, you can incise the valve. At the same time, you can do a refluxing ureterostomy, which allows the bladder cycling, which allows the baby to pass urine per urethra, but at the same time keeps the upper tract protected, because whatever high pressure, the urine would leak through this refluxing ureterostomy. And so the various ways of temporary diversion in valve patient apart from valve incision could be vesicostomy, low refluxing ureterostomy, bilateral ureterostomy, and high ureterostomy, which is now no more done. It used to be done in the past, but now most people do low-level loop ureterostomies. The other way is to put a Mitrofanoff channel, which anyway is needed in the long term because of the polyuria, and then you can put a catheter and keep the bladder on drainage. But in the long run, this Mitrofanoff channel has got a lot of use because their patients are polyuric, the bladder is decompensated, there's a lot of post-void residue, and maybe they can manage during daytime, but at nighttime for nighttime drainage or for the residual urine. So this Mitrofanoff channel or continent catheterized channel is a very useful thing in cases of posterior urethral valves. So there is a prevalence of end-stage renal disease in 20 to 50% of cases. There are risk factors for these cases, how to manage them in the long term, how to assess them for prognostic factors in the long run. Those with good kidneys, the two good kidneys, they can be dealt with by just valve incision and they do better. But anybody with valve, with a diagnosis of valve has to be followed for their lower tract urodynamics lifelong, because their valve behavior changes with time. In the beginning, they are usually hyperreflexic. Then they later on in life, they can decompensate and become atonic. So they have to be assessed urodynamically with the various ways I will present in the next few slides. So the risk factors that at prenatal age, if the bladder, the valves are picked up early in the prenatal period, then they tend to have worse prognosis. Their renal damage is much more. They have much more renal dysplasia, or they are with or without VUR. If there's VUR, then they have worse prognosis. Nadir creatinine 1 year of age is of extreme relevance. If after decompression, after management, after taking care of the sepsis, the creatinine, whatever is their nadir creatinine at the age of 1 year, that reflects their long-term outcome from the point of nephrological outcome. If until unless they develop another sepsis or pyelonephritis, if they are managed well, even then this residual function tells you that how long they are survived. So the 20 to 50% with a poor creatinine at one age will go to end-stage renal disease. And then bladder function management, how bad is the bladder, how good is the bladder also, and how do you manage this bladder urodynamically, and emptying of the bladder and decompress the bladder, does he empty well? All these things are of prognostic importance. So one of the ways they need to be followed up, apart from their voiding history, voiding stream, once they have incised, you can see on ultrasound the upper tracts, and you can see the residual urine in the bladder. You can do a uroflowmetry, much more objective. If they are doing, those who are voiding with a good parabolic curve, that means the bladder is good, they are not obstructed, there is no residual urine, they will do better. But those with residual urine, obstructed patterns, they are likely to be worse. So that is those will be the one who will need proper urodynamic with cystometry, voiding pressures, filling pressures, entry pressure. All these things are important, because just like in prostate, you have seen that they can be, the bladder can have irritative symptoms, or they can be an unstable bladder. You can have UDCs. Similarly, with this obstruction, the bladder can be hyperdynamic, hyperreflexive, there are unstable contractions which can damage the upper tract, or they can be non-compliant bladder, because with thick wall, the more and more collagen is there, they can be non-compliant. And then later on, some of these bladder can become atonic. The reflux urine goes up and come back. They're never allowed to relax. They're never allowed to rest. So there is a variable urodynamic behavior from every patient. So individually, you have to evaluate them, particularly the one who doesn't have a good flow. They are not good stream. They are not emptying. They need to be evaluated thoroughly with the proper urodynamic, complete urodynamic cystometry, voiding pressures, and have to be managed accordingly. And as I mentioned earlier on, all these factors like polyuria, poor bladder compliance, residual urine, I have highlighted again and again, because this leads to well bladder or well bladder syndrome. And unless you manage them well with the help of voiding training, behavioral therapy, timed voiding, um, double void so that they empty completely, or nighttime drainage. There are various ways of keeping the upper tract decompressed, keeping the bladder empty, and then some pharmacokinetics like anticholinergics, alpha blockers, all they have to be used in according to the urodynamic findings and their 24-hour urine volume, their nighttime volume. All these things are so important that they need to be assessed. You can put a buprenorphine for nighttime drainage. That is a very useful tool. And some unfortunate ones who have gone into end stage, or they have a very non-compliant bladder, would need reconstruction with augmentation, or would need a transplant. So there can be various kind of bladder presentation. And these patients, they can have a large atonic dynamic bladder, they can have a very poor compliant bladder, or they can have in between. But you can, in most of these stages, in the moderate ones, you can make the difference by taking care of them from the very beginning, by assessing them again and again, their voiding training, their behavioral training, their pharmacokinetics. All these things are important. I think I have already mentioned about this, that you don't, but the thing is that need to educate the child as well as the parents. You can't push this child, and the parent should not push the child don't expect that they will void like any normal child from the very beginning. Their daytime continence is delayed. They can have nocturnal enuresis for a while. Those who have nocturnal enuresis or they are incontinent, this is a kind of a safety valve for them. Any high pressure, it's not going towards the upper tract, perhaps they are leaking. So it should not be discouraged, but you should try to improve them socially and medically as much as you can on the basis of with the kind of management plan I have described. I think, thank you. I would like to give you some time for discussion. This is a kind of topic where I can only highlight some salient areas, and it would be easier for me to answer your question according to your.
So thank you, Sajid, again. Now, right, there's one question by Dr. Majid Kakafel. When we decide either to make a unilateral refluxing loop ureterostomy or bilateral ureterostomy. So what I understand from the question is that if you have obviously PU with bilateral reflux, can you get away with unilateral ureterostomy?
Yeah, to be honest, the first objective is that don't make any ureterostomy. If the bladder is not bad, the kidneys relatively are good, patient can come for follow-up, can be brought for follow-up. And then first thing is the only incision of the valve and relief of obstruction. Then you observe the child. If he's not emptying well, if he's repeatedly having sepsis, then or they live far away, then the next protective thing is unilateral refluxing ureterostomy. You don't need a bilateral refluxing ureterostomy. Bilateral ureterostomies are usually done when they are obstructive refluxive or obstructive because of thick walled bladder. The intramural portion of the ureters get obstructed and they don't drain even if you have incised the valve. So those cases may need bilateral ureterostomy.
Right. About the closure of ureterostomy, if the ureterostomy is done, what's the right time for closure and what clinical parameters would you look at when you decide about closure of the ureterostomy?
I think the right time depends on many aspects, which include the patient presentation, what are the renal reserves, how is the bladder, what is the socioeconomic status. Again, they can come for follow-up because the reason you have done it is that mostly you can delay it up to the school-going age, because anyway for a year or two these kids, these babies are in diapers. So till they are diapers, till they are not being trained for voiding, then they can easily be in that. And that also avoids repeated visits of that baby to the urology clinic. And if you try to just do it early, then if he goes into sepsis or infection or you ask for repeated visit, that's usually not appreciated. So once you have done that, I think both social factors and the clinical factors need to be taken into consideration.
I think you have touched upon the valve bladder, but the question is that how do you treat the valve bladder syndrome?
Well, again, valve bladder syndrome, let me give you just idea that those with polyuria, nephrogenic diabetes, insipidus, people have tried ACE inhibitors, but that's not my area because I'll not touch upon that, but they need to be under care of a nephrologist if they have renal dysfunction particularly. And severe renal dysfunction, CKD3, CKD4, they need to be seen by a nephrologist to avoid osteodystrophy, metabolic acidosis, all that. They need vitamin D supplement, they need soda bicarbonate. So that's one aspect. Coming to well bladder can be managed depending on how much urine output they are producing and what is the compliance of the bladder. So urodynamic assessment and their urine output, they are two important factors. And then either you can manage them by just double void and time voiding if they can empty, because the refluxing urine is coming back, or they are polyuric, they are repeatedly filling the bladder. Not what happens that a lot of times is a non-compliant bladder, even if they are not refluxing, once the pressure increases in the bladder, a lot of urine is stored in the upper tract. And when the baby or the boy voids, as soon as the bladder empties, the stored urine in the upper tract comes back to the bladder. So it refills again. The bladder doesn't get time to rest. Either it is a refluxing urine or obstructed urine into the upper tract because of less compliant bladder. So the bladder need to get some rest in between. So those bladder which do not get rest for some reason, they also get converted into. So you need to either double void time and tight voiding to keep the bladder empty and give them rest, or provide some kind of diversion with which they can do intermittent cath and take away the residual urine. And particularly at night time, because when they are sleeping for 8 hours or so, if you provide a nighttime drainage, that gives a good 8 hours rest to the bladder. And all that obstructive uropathy effects on the kidneys are avoided during that period. And the bladder also gets some rest. So these are the different measures to manage. And then you can take help from anticholinergic. You can allow better emptying by introducing alpha blockers. Sometimes, as I mentioned, that even after valve incision, there is bladder neck hypertrophy. It can be cause of second obstruction. So you need to see for sure by doing a urodynamic that there is still a high voiding pressure. So, and at what level. So if you do a video urodynamics, can be very useful. So it's a very complex things, to be honest. And every patient has to be individualized, and you have to use all armamentarium. You have to see their voiding, you have to see their uroflowmetry, you have to see their residual volume, you have to see their 24-hour urine output, particularly nighttime volume, and the bladder compliance you have to assess objectively with the help of urodynamic. And then all this information helps you to manage individually. Some simple measures like voiding training. I am repeating the same thing again but they are very important. Time voiding, double voiding, nighttime drainage. These things are absolutely important.
Anticholinergic, nighttime drainage.
About the use of anticholinergics, do you have an age cutoff for the use of anticholinergics in very young children?
No, you can start anticholinergic at any age. It depends. 1.1 milligram to 0.3 milligram per kg is the dose, and you can give the dose according to the weight of the child.
So, I mean, we know that PUL is
anticholinergic is again a double-edged sword. Sometimes they start retaining urine because of anticholinergic. So when you are giving anticholinergic, you have to review again and again for the residual urine. And if they are keeping a residual urine, then you may have to taper it off or withdraw, because the bladder become non-compliant, because residual urine is a disaster for these kind of bladder. Or you have to introduce some kind of CIC along with it, normal voiding, to give rest, to empty the bladder. So these are complex management. What I want from these residents, that they should have concepts of valve pathology and should know that it is a complex problem and these patients need to be followed up thoroughly all their life. And definitely once they start dealing with them, they will understand
Ultrasound,
pathology,
UDS.
manipulate or
Yeah.
I request
update
other people to keep
to
their audio closed, please.
manage them.
Right. Yeah, I think the issue related with long-term follow-up is something that goes hand in hand with EU valve. There is questions about, I mean, we know that instrument was one of the handicap finalist instruments. So what is your youngest age in which you can do a valve resection, or you prefer to do a valve resection?
If the baby does not have a atretic urethra, we can do it in a neonatal period even. But usually it takes that much time for patient's evaluation, and that it is very rarely done in the neonatal, but you can do it. It's even if you have a 7.5 French offset lens, you can use a Bugby to ablate that valve. And that's what we have done in cases. So you can do a neonatal period, but definitely the bigger the child, it depends what facilities you have, what expertise, how fit is the child. The problem is that if it is in the safe sepsis, anesthesia-wise, the baby is fit, then you can do it. Otherwise, if you have diverted with a feeding tube or a mini P, and you have done a cystogram, there was no sepsis, and you can do valve incision or ablation at that time with a Bugby, with a 7.5 cystoscope. 7.5 cystoscope can easily go through a neonate.
Right. Questions about would you do a urodynamics before closure of the uretrostomy? You need to do a comprehensive analysis. So yes, please.
Definitely. All these patients have to undergo all kind of evaluation, which I have repeatedly mentioned. They need to be seen how they are avoiding perutha with other kidney. If it is unilateral, a bilateral, then you need to. Bilateral is a real pain because the bladder has not been functional. There's no simple way of assessing the bladder. There's no way of cycling the bladder. So, but you can assess with the cystogram. You can assess with the cystoscopy. What we can do, that we try to close one uretrostomy at a time. And we try to do it with a poor functioning side first, so that it drains into the whatever damage, if happens to that side, it will be a bad side. It will poor functioning kidney, the better functioning is still preserved. And then that cycles the bladder. Because we usually, if we did the uretrostomies only and we did not incise the valve, then unless patient voids through the urethra, we don't incise the valve in a dry urethra. So
about bladder augmentation in PU valve children who have smaller capacity, I mean, ideal would be that if you have a dysfunctional or a very dilated ureter on one side, you would prefer to use that ureter for augmentation, or would you still prefer?
That is written in the literature, that is recommended. But personally, I am not in a favor. I've done some ureteric augmentation. I don't think these ureter are also compliant because they are diseased bladder. They have fibrosis in their wall. Let them be very dilated, but they are not compliant. So I don't think this, in my personal opinion and experience, I'm not in a favor of using ureters for bladder augmentation. But this is, I would not deny, if any student or any trainee answers a question and uses it as an option, it is very valid. It is in the literature. People favor it. People recommend it. So my personal bias is against using ureter. In my opinion, they are disease ureter. They don't work well for augmentation.
So probably the logic of using it is to use a urothelium which would not reabsorb urine, rather than small bowel, which obviously would cause metabolic acidosis and stuff.
That's the whole idea. I mean, that is the whole advantage of, that's why people recommend it. That instead of using bowel, which absorbs and lead to hyperchloremic acidosis and particularly renal function, and they say that this is dilated ureter. I'm not sure how many of them have really presented their series of bladder augmentation with, if you go to the literature, you will not find a lot of series with a thorough evaluation of these ureteric augmentation. And I have done it myself because I was I read in the literature, I tried it, but it didn't work. So I have stopped doing it. And there is a logic behind it in my view that those ureters are unhealthy ureters, and unhealthy tissue, like a bladder tissue, they will never behave the same way. You know, the bowel, you do augmentation in your bladders in adults. The bowel is a healthy bowel, and it stretches and it thins out and it accommodates with time. So that is the difference. People use muscle. People use mucosalized bowel even. And there are the papers in the literature. We did one in our center. That didn't work as well. So there are many ways, but I think the conventional way of augmentation with a bowel, a small bowel.
Yeah, I mean, you mentioned about the residual urine and its deleterious effects on the upper tract and the bladder function as well.
Function.
How do you assess residual urine in a child with continuous yo-yo reflux of urine coming into the bladder? You empty, no sooner you assess, there's some urine still coming in from the upper tract down into the ureters. So is this a practical difficulty in assessing the residual volumes?
I mean, the residual urine, you can, once the patient, you were talking about not avoiding trained baby, or you're talking avoiding trained baby?
No, avoided trained babies, because otherwise it is not.
I mean, definitely you ask them to avoid, and and you have already assessed them for reflux, whether it is coming through reflux or for non-reflux, if it is a residual urine, or it is because of bladder outlet obstruction or decompensated bladder, it is a residual urine. So any residual urine is harmful, significant amount of residual urine, which is more than 25% of the bladder capacity. And if it is less than 10% of the bladder capacity, you can ignore it. So any significant residual urine is hazardous for bladder, because the bladder doesn't get rest. Bladder need rest in order to function properly in the long run. So one way or the other, you have to avoid that.
Okay, Sajid, one of the last question, and I think it's pretty straightforward, about the urodynamics, and they say that how would you assess the pressures, the bladder pressures, when there is so much of reflux? So obviously, the voiding the CMG or the voiding cystograms is the standard urodynamics for. Would you agree with this?
Awesome.
Hello.
Hello.
Hear me?
The question was about urodynamics, and the fallacy could be with pressure assessment of the bladder, because there is dissipation of pressure into the upper tract. So video urodynamics is the standard urodynamic evaluation of children with DUL. Would you agree?
Yeah, it is difficult. You know, in urodynamics, we have to decide beforehand what is our urodynamic question. What do we want to see? What question do we want the urodynamic to answer? Sometimes it can answer, sometimes it cannot answer. But doing urodynamics in a patient with reflux, we can judge a lot of things. Is it a low pressure reflux? Is it a high pressure reflux? Is it a reflux on voiding? So then in those circumstances, the patients are managed differently. If, of course, it is a low pressure reflux very early, That's why video urodynamics is so important in these cases. So that you have to see that. Then you cannot judge that bladder. Then in those cases, what you need to do, you need to put catheters into the urovesical or opening, inflate it, and that can be done under anesthesia. And we have done that. You inflate them, block them, and then you fill the bladder. So there is no simple way of looking at the bladder dynamics in those where you want to do a cystometry, you want to see compliance, you want to see bladder capacity, and there is a low pressure reflux, free reflux. At 5 ml, 10 ml, 25 ml, it refluxes into the upper tract. But there are different ways that what we do, that in some cases, we fill it to the capacity, and then what we do, that we empty it quickly, and then we see that first it will always be the bladder volume which will come out, and then the upper tract reflux volume will come down into the bladder. So these are the ways to judge different what percentage of that filled contrast went into the upper tract and what percentage remained into the bladder. So they are not very accurate, but the most accurate way would be that you block the uretrovesical junction under anesthesia with the balloon and then fill the, so that will be urodynamic under anesthesia. That will give some kind of assessment of the bladder under anesthesia.
Right, Dr. Sajid, thank you very much. I think it's a very exhaustive session for you particularly. But I really congratulate all the audience, online audience, who have stood throughout the 2 lectures, and they were very engaged and very involved. So congratulations.
Well, and the effects of the bladder, the urinary tract, and because it's not a simple pathology, it's a very complex pathology to understand.
So thank you very much. And for all of you, for tomorrow, we have 3 lectures starting at 3:30, in which Sajid Solat is going to talk about ecstasy, which again is a very interesting and a very fascinating subject. We will have Sadaf talking about the various intra-abdominal malignancies, particularly the Wilms tumor. And then Dr. Zahir, who is another fellow trained from Sajid's unit, will be talking about bladder dysfunction. So some of these things will be again repeated in tomorrow's last topic. So thank you very much, Sajid, and for the whole team. And see you, inshallah, tomorrow.